Stop the recording for now. What is this? So in the interest of time, let's start this session. And I believe this will be the last session of the series. I think Adina is probably happy. I don't get to pick on her anymore, right?
Think
Right?
that's I'm fine with you picking on me. It's my learning, so
All right. Don't scold me later or tell bad
that
things about
no,
me.
not gonna happen. I am glad that you pick on me, so it's just for my learning. I
Good.
like it.
All right. So I call this session the dangerous questions, but I think we'll probably look to cover some of the questions that you guys have and situational questions. I think Adina mentioned that the place where she will be interviewing at, they have been asking a lot of situational questions. So we'll touch upon them as well. And we did touch on them in the past sessions, but we'll proceed further. I think the first question we'll talk about today is how do you make a patient comfortable? And that's going to be the one that's going to be the starting question. And then how to deal with an irate patient or a patient that is upset. I think we touched on that topic before. So we'll see if how many people are, comfortable with that type of a question. And I think a few more questions can probably come for you from you guys on what you have heard, and we'll look to address those. And yeah, so let's see. So Dr. Smith or anybody is asking the question. So of course, a patient, whoever is in the hospital, he or she is in an unfamiliar environment, and if you are seeing the patient for the first time, how do you actually come to open up the discussion, open up your conversation with the patient? How do you make the patient feel comfortable? So that's the question. All right. Um, and as all of our participants know, the first priority for any physician is patient care, patient satisfaction. And that is huge. And hospitals, doctors are all rated these days based on patient satisfaction scores. So you are basically a service provider. You are basically you're basically Disney, where the patient is never wrong. Patient comes first. And that's somebody shared with me in the past that the 10 commandments of being a physician. Number one is the patient comes first and the patient is always right. So, anyways, that's just a little bit off topic. All right, so let's give a sort of a sample template answer, perhaps, right? Dr. Smith, that is that is good. That is great. And yes, we are here for our patients, and making a patient comfortable, I believe, comes from trust and showing genuine empathy. And to begin with, of course, I would always knock on the door and is it okay to come in? Uh, I will start by introducing myself and explain my role. And that is, I believe, is fairly important. And I will look to address the patient by the patient's name. I would look to open up the discussion by establishing a simple line of communication, probably a non-medical question, an open-ended question. How are you feeling today? Did you manage to get some rest overnight? So I will look to develop a bit of a warm and an approachable atmosphere and develop and initiate a conversation. And as the conversation engages further, I would look to make a conscious effort to explain in layman terms any procedures, any diagnoses, a reason for taking a medication, so that the patient is fully informed and not, in a way, not overwhelmed. So this is how I would look to approach things. And I would like to meet the patient where the patient is at. And I think that probably will go a long way to make a patient comfortable. And at the same time, always asking for the patient to possibly repeat what I have said so that I know that they have understood. Thank you for asking. All right, so that's just a typical type of answer, something that you should be ready to provide uh, on any of these types of questions. So, yeah, anybody wants to give it a try? So, so doctor, so how would you approach a patient that you are seeing for the first time in a hospital setting, perhaps? Anybody wants to give it a go?
Oh, I can give it a try.
Sure, yeah.
All right. So first, I kind of greet them and I might say like, "Hi, good morning. How are you doing?" And then introduce myself to them. My name is Dr. Samid, and then what my role is in that capacity. Um, Ask them how they're feeling, and for example, if I'm there to discuss their disease with them, I might understand them. I might ask them what they know about it to see what they understand about their own disease, and then try to carry the conversation forward from there. Make sure they're comfortable, and try to be really approachable towards them.
Yeah, that's good. I mean, that's, yeah, reasonable. And if you want to be a real pro, you will mention, I've heard that patient satisfaction is of utmost importance here in the US. And that's not just for the sake of metrics. I would want to be that physician that the patients can trust, the families can trust, and someone that they will look forward to seeing in a coming visit. I mean, just share that you know about how important patient satisfaction is in the US. That'll just go a long way.
Sure. Thank
Uh,
you.
all right. Anybody else wants to give it a shot? Let's
Did
see.
I give you a chance to pick up on me again?
Let me pick on somebody else.
Okay.
Okay, Mahin Ejaz.
Thank you so much. Okay, let me just try. First of all, I'll knock at the door and enter the room and introduce myself. I'll start the conversation by introducing myself like, "Hi, good morning. My name is Dr. Ijaz, but you can call me Rahim." And I'll ask him how he or she would like to be introduced and called. And I'll start the conversation by asking how are they feeling, and I'll just ask them why are they here in the hospital and try to have a know-how of how much they know about their health and the problem. And I'll start with an open-ended questions and let them lead the conversation and interaction. And that's how I'll start the conversation, and I'll carry on from that piece.
All right, very good. And I think you mentioned a good approach that you ask the patient, hey, who do you want, how do you want to be identified? What do you want me to call you? What do your friends call you or anything similar? All right.
Yeah,
Um, okay, so I'm okay if there's FBI in this group, but who is this anonymous individual?
thank you.
Thank you. Who is this anonymous guy or gal? FBI, CIA, who are you? Let's see if I can find some information about this person. View profile. Oh, profile is hidden. So- Anyways, okay, they can spy. All right.
I think he's one of our senior
Okay, then how do you know?
because he told me a few days ago that he will join in with anonymous name.
That's funny. Hey, you gotta show yourself. Anyways, he's not complying. Tell him I don't like this. Send him a message. You have his phone number?
Yep.
I think he's listening or not. Tell him I don't like this. He has to be brave enough to show his name. Hey, Adina, is it okay I pick on him like this?
Why are you asking me?
Bouncing off ideas that everybody needs to, discuss
Yeah,
all this.
yeah. I mean, it's okay as long as you are picking on us. It's okay.
All right. All right. So a newcomer, Isra Khalid, can you go and respond to this question?
For sure, of course.
How would you make it comfortable for the patient to have a conversation with you?
Okay, that's an interesting question. Of course, during our time in training and also being a physician in general, we are bound to encounter patients that are difficult and sometimes they are having a bad day. So, what I would do personally is obviously knock on the door, introduce myself. First, I would, make the patient comfortable, maybe have a small talk with the patient initially, like talk about the weather or something in general, maybe Super Bowl or NFL, whatever, find a relatable topic just to break the ice, and then ask the patient about their day, how they're feeling. If I'm just checking up on them, I will just follow up with the condition. And if it's a new patient, obviously, I'll initially start with what brings them to the office or what brings them to the clinic. And yeah, like you said, ask open-ended questions because I think that's the best way to lead the conversation and end the conversation with getting a little bit of feedback from the patient, like make sure he understands what I'm saying and if he has any questions or anything like that. So that's how I would approach the question. I'm just landing on the most difficult Zoom meeting, but
No,
it's
no, no.
okay.
We'll have more difficult questions, right, Adira?
Definitely, definitely.
Okay. She's ready for it. That's why. All right. So yeah, that's good. And you mentioned a very pro tip that is build sort of a common ground.
Mhm.
Ask about the Super Bowl or something relatable.
Whatever is current, yeah.
Yeah. So just do. Hey, did you watch the game? Did you catch the game yesterday?
Mhm.
Something similar. All right. Okay. Adina, so you can go ahead.
Okay. Yes, definitely. I believe building a relationship with your patients is really important, and making them comfortable is an important part. So what I would like to do with my patients is to greet them and introduce myself first, and make them comfortable around me, making a small talk, and make sure that they are comfortable. Ask them about their needs. I am always willing to listen to my patients and build a good rapport with them so they can talk to me about their concerns. And really, I can definitely tailor my treatment or management plan according to their needs. So I guess that's how I will treat my patient, and I will willingly listen to them to make them feel comfortable and heard.
All right. Okay. Anybody else wants to give it a try, or we can move on to the next question? All right, so we can move on. So I think next question, let's touch on a question. I think I mentioned this earlier. What was it? Somebody remember? What was it? How do you deal with a difficult patient? How do you deal with a patient that is upset and argumentative? How do you deal with such a patient? Anybody wants to give it a shot?
Sure.
All right.
So first, I try to understand where they're coming from and validate their emotions. Um, just make sure I hear what they have to say, whatever issue they're facing right now. And I try addressing that in the most respectful and polite way I can. Um, and I hope that that will de-escalate the situation a bit. And then I try to explain to them what I can do to help them out in this situation, or what we can do uh, as physicians generally.
Right. Okay, great. Anyone else? Rabia Aslam.
Um,
You want to
for
take this one?
for a difficult question,
Yeah.
um,
So,
you can hear me?
yeah, we can hear you. So let me be the interviewer. So Dr. Aslam. So, we all like to see happy patients, but of course, we will encounter patients who are not satisfied with their care. It could be their medication is late, they're in a lot of pain, or they're not sure what is happening. They're not aware of the plan. It utterly
Mm-hmm.
possible that you have already told them the plan, but they're still not happy. How will you deal with such a patient or such a scenario?
Uh, First of all, I will apologize for anything that is happening with the patient bad, and then I will try to dig out like what's the actual problem the patient is facing, and then if the concern is genuine, I will validate his feeling and will try to solve the problem and try to resolve the issue in my best capacity. And even if still the patient is not satisfied with, then I can involve my other seniors and colleague to resolve the issue.
Okay, that is one good approach. And let me just say a few things. All right, yes, that is a very good question. And you're absolutely right. It does happen that you meet a patient who is not satisfied. And to be honest, the patient is under a lot of stress. The patient might not be getting enough sleep. The patient may have medical issues that are not 100% clear. So you can honestly understand that this is always a taxing situation for any patient, a happy, healthy, or any other patient. Patient, I've been informed, is not doing that great or is not is a bit upset. I will
Yeah.
first come and introduce myself as normal, and I will see the situation. I will definitely ask the patient first if anything is bothering the patient, and if they mention something, then I would definitely say I truly apologize for any of these issues that you are facing. And I will tell them that I hear you and I'm here to help. And please tell me a bit more about your problem so we can better understand and address any of your concerns that you are having. And we will sit down instead of standing. We will try to sit next to the patient and try to learn from them what is actually bothering them and look to address that. And at the same time, we will definitely mention that I know things have not happened as per your 100% satisfaction, but 100% satisfaction is my goal, and I envision that we can definitely help you out. So I would look to bring them at ease and allow them to develop a conversation and share their experience or stressor that they are going through. And we will look to address their issue. Hopefully, this will assist in normalizing and making the patient to be much more appreciable of the care that we are looking to provide. Yes, any other question in this line? I'll be happy to address that. So yeah, something, anything casual, approachable will work. You just have to have the right mindset about these type of questions. Just to the patient care is number one, and you can come up with anything that you suggest. I think Rabia had a good approach to this. She said you will apologize, even though it may not be your fault. But since this is Disney, you apologize for anything that happened to the patient, that anything that the patient is upset about. So good point. All right. Anybody else wants
Thank
to
you.
take
Thank you
a?
for feedback.
Thank you. No problem. Anybody else wants to take a jab at it? Let's get Anonymous to talk. Hassan, no? Did you get in touch with Anonymous? Look, Hassan's also missing in action.
No, no, he's not comfortable.
Okay. No, it's okay. Hey, no worries. You can just log out, come back in with a real name, and it's fine. Okay, Hassan, do you want to go ahead with this answer?
Okay. Okay. So the same way I will knock the door. I will introduce myself, what's my role, and then first of all, I will try to find out what is the root cause, what are their concerns, feeling, or expectations that were not um, expectations, etc., are the root cause behind their concern or the stress. And then after that, we will apologize the patient for whatever is bothering them. And then after that, we will try to bring them at ease. We will sit with the patient and tell them, like, even though we know that you are not 100% satisfied, but we will try our best to satisfy you. And I think uh, we will try to find out the solution.
Okay. All right. Um, all right. That's fine. That's fine. Anyone else? Anyone wants to give it a go?
I can try doing it.
All right.
So if like, do you want to ask the question?
Sure. So, Dr. Khalid, well, we all would be happy if we get the nicest patients, right? But of course, it could happen, especially in a hospital setting or even in a clinic setting. They are upset. Their medication could be late. Their somebody did not inform them of a result that they were expecting to hear. How would you deal with a patient that is irate, that is upset, that is angry at the care that he or she has received?
Okay. Of course, that's a very valid question. If I were to encounter a patient that was irritated or angry, the first thing obviously would be to introduce myself in a very compassionate manner. And the key would be communication, trying to understand the patient's perspective in the scenario, trying to understand what is bothering the patient would be my key focus so that I can best address the problem at hand. And obviously, because as we all know that patient is the top priority for physicians, I would focus on how I can solve the problem to the best of my abilities. So that's how I would approach an argumentative or an irritated patient.
All right, fair enough. All right, so let's jump to another question. And I think we did discuss this in a previous session. Let's talk about if they ask you, so I know you guys are all trying to match. What if you don't match this year? What if on match day you do not get that happy email? What would you do about that? How would you approach that? Anyone?
I can do it because unfortunately I did go unmatched last season.
Okay.
Unfortunately, yeah, it kind of broke me, but I rebuilt myself. So, I mean, if I were to go unmatched, I would obviously it would be a devastating thing. Initially, it would be a big shock, but I would try to really reevaluate myself and do catharsis of where I went wrong and try to evaluate what I can improve in my CV and come out stronger because I'm the type of person who always sees the light at the end of the tunnel. So I know it would be a very difficult thing, but the best strategy or the best mindset to have is to see the silver lining. And that's the kind of energy that I harbor and try to cultivate.
All right. Very, very reasonable. Anyone else? I would want to provide a little bit of feedback. I would want to suggest what I will be doing to improve my application further and how I would potentially be an even better candidate. So let me just give it a shot on this answer. Yes, I think that is a possibility, and many IMGs do not match their first time around. And I hope that's not me. Yet I do believe that if that does happen, I will realize that is a aspect of life, and I will look to see how I could overcome this potential setback. I would analyze and see where I have gone wrong or any shortcoming that I've had. And that could be, let's say, for example, it could be my scores weren't the best, perhaps. I haven't done my step three yet, perhaps. My interview preparation was not up to the mark, or my CV was just not as competitive compared to others based on the amount of clinical experience that we have all gathered thus far. It could also be that my research experience is not the best, and I would look at each and every one of this aspect and evaluate for myself what can be improved. How can I be the strong candidate that I do believe that I am? And I do believe that I am a fairly strong candidate. In any way, I would look to find any deficiency and try to overcome it and come back next year even stronger than I am right now. And I would stay positive, stay committed, and that how I have always been throughout my life. And yes, I do hope I match. I do hope I match at this program. But yes, I am looking forward to succeeding. And if not, then I would have a game plan in mind. Okay. Just I think this is what we discussed in the previous. You just need to have a plan. Just need to have a plan. So anybody else? Azim, Dr. Azim. Azim, Dr. Azim. I think you were in a session before. Dr. Usama Ahmad.
Yeah, is it okay to be a silent listener?
Well, you well, it's perfectly fine. No, there's no pressure, but it's very easy. I mean, I think is you'll have a good time practicing, and hopefully that helps you out for your interview. That's the only thing. Otherwise, it's up to you.
Yeah, I really appreciate it. I would be participating, yeah, after a while or
Okay.
in the next section. Thank you. Thank you. Really appreciate it.
All right. No worries. Okay. All right. Is Maheen here still?
Yes, I'm here. Can you please repeat the question again, please?
Sure, sure. So Dr. Ijaz, I hope you match, but in the event that you don't match, how would you handle that situation? What would you be looking forward to?
Honestly, uh, Dr. Khan, I have tried my best, and I think I'm fairly a very good candidate to match for this year. But unfortunately, things happen, and if I don't match this year, it will definitely be a big disappointment and shock, naturally. But I will just take some moment to analyze the whole situation and do a catharsis of me. I'll just, first of all, I'll go to my comfort people so that they can have a know-how of the whole situation and they can provide me with that comfort that I'll be needing at that moment. And then I'll start analyzing my CV and my interviews as well, that where I went wrong. And I'll work on that. And for the next year, I'll try to come as even more stronger person and a candidate. So I think, but I do hope that I'll match in a very prestigious program like yours. Thank you so much.
All right, very good. Anyone else? Adina.
Okay. Well, I hope it doesn't come to that, but unfortunately, if it does come to that, I will take a moment and see why the setback happened. We'll put everything, my whole journey under a microscope to analyze and evaluate where I did what I did wrong and where it went wrong. Hopefully, I think I believe that I am a good candidate and I have everything under my belt, so I should match this year. If not, then I will be start working on my weak areas, which would have been pointed out by my mentors or by other people, or maybe some areas in my CV. And then I will reappear stronger, more resilient, and more dedicated, definitely. And hopefully, it won't come to that, but definitely I'll never give up. That's the spirit I am. I am. That's the spirit I have. Thank you.
All right, very good. Okay, so let's probably move on to another question. Um, let's see what we can come up with. Um, all right, so let's say, for example, what would your friend say is your biggest weakness? think we had a whole session about the weaknesses question, right? So what would your friends say is your biggest weakness?
Can I give it a go?
Sure.
I think my friends would say, like one of my, first of all, it's an interesting question, but I generally I would say me being a little too gullible at times or trusting people too easily.
Okay. All right. Anyone else? That's an atypical question, but I've seen it happen. What would your friends say is your biggest weakness?
Well, I think what my friend would point out is my biggest weakness is not giving them enough time because I have a lot of friends. So it's very difficult to give every individual their due time. So I think that would be my biggest weakness in their eyes.
You seem to be a very social person then. What is this? We gotta get you some work to do so that you don't waste time with friends.
Yeah. Okay.
All right. Anybody else? So I mean, these questions are just for you to think outside the box, in a way, so that you can handle any silly, stupid question coming up. Rabia has her hand raised.
Uh, uh, I I just want to ask, like, if you're answering this question, like, if I say, like, my friend described me as a workaholic, and I almost busy every time in doing something uh like educational or something other. So, like, do we have to give something that we are working on it, or not? Like, is it okay just to describe our weakness, or we have to like defend it?
Well, you could defend it if you want. If it's if it's very genuine, you may not necessarily need to. It's something that's relatively casual. Uh,
Mm-hmm.
that's fine also. Um, I think these are more just to have a nice conversation around. Maybe they'll ask
Mm-hmm.
you a follow-up question, but this is just
Okay, but
yeah.
would it give a bad idea, like, if I say, like, I'm a workaholic, so would it give a bad idea that I may not socialize enough, or I may not have enough leisure time? So, like, what's your thought on it?
Workaholic. Well, you can say that whenever I'm doing something, that's what I'm doing. If I'm focused on something, that's what I'm focused on. And my friends may get irritated that, let's say, for example, if I'm studying, I mean, they would want to
Mm-hmm.
go out for a movie. I would say, no, I have to get this done. So that could be
Yeah.
irritating for my friends. For example, if I'm that focused that I want to go to this restaurant, sometimes I may not be that flexible. But yeah, if I am feeling that I want to have this taste in my mouth, then I will only go for that restaurant. Or so yeah, and if I decided, okay, this is the vacation that I want, I would want that vacation. I would push for it. Um, yeah, but I've been flexible, but I think that's what my friends will say, that I'm a little stubborn on these things.
Okay. Okay. Thank you. I
All right.
appreciate it.
All right. I want to touch back on a session that we,
Can I? Okay.
yes, you go ahead.
Okay. So, the biggest weakness by my friends, right?
But yeah, so if your best friend, what would your best friend describe as your biggest weakness? What they really don't like about you?
Okay, so my best friend will definitely say that I'm a big foodie. I'll exchange a medical advice for a plate of good pasta. So I think she'll just describe me that I'm a very big foodie, and that might be a big weakness for me sometime.
Okay, all right. Um, yeah, well, this is what I say. If you feed me, I'll do whatever you want. That's okay.
Yeah. Yeah.
All right. So, all right. Okay. So maybe back to a serious question. And I think I think that was a pretty stressful session that we had. And that was around, tell me about an interesting case. Who remembers that session? So you must be ready by now for that. All right. So Adina, you want to go first?
Okay, I actually tried it yesterday.
All right, good.
Okay. Um, yes, I think I have seen a lot of interesting cases during my house job and observership. Like one interesting case I want to mention here is from my house job. So 68-year-old male coming to us with presenting complaint of with a presenting complaint of shortness of breath and increased work of breathing. He was hypertensive and diabetic. Um, so vitally, he was a little bit tachypneic and tachycardic, and O2 sats were at 92 on room air. Um, Past medical history was not significant other than hypertension and diabetes. And so we perform a physical examination. So physical examination was remarkable for basal lung craps and increase respiratory rate. But the strange thing happened when I was doing a physical examination. I noticed that his pulse was very high volume. I can feel that this is something that I haven't come across very often. And there's a head bobbing in that patient. So I perform a thorough examination, and when it comes to cardiac examination, I try to listen for a particular murmur, which I couldn't appreciate much. I did my due diligence, and I completed all the systems, and it was not revealing much. Um, Lab work was we perform initial investigation with baselines, and it shows a mild anemia and increased leukocyte count, which we suspected. And chest X-ray shows pulmonary infiltrates on the left side of the lung. So we suspected it might be a case of viral sorry it might be a case of community acquired pneumonia. So we started him on antibiotics and supplemental oxygen, and improved. But when I was presenting this case in the morning, I particularly emphasized on my finding, which I found a little bit odd. And I told my attending that he has a pulse that is very high volume, and when I tried to perform a particular maneuver, I felt that this might be a water hammer pulse. And obviously he asked me if there is a murmur, which I couldn't find, but I asked him like if he could appreciate a murmur, then because of my inexperience. And and I also asked him that if he could get an echo for that patient, because I had a suspicion that there might be something wrong with the head bobbing and high volume pulse. And so we end up getting echo, and the echo showed moderate to severe aortic regurgitation. And so that was very interesting case for me for two aspects. It was a very educational for me. It was very educational for me. And also I was very vigilant for unusual signs. I think a physician, a good physician, should be looking for some signs that can not be present in normal patients. So I think that's why this particular case is interesting to me, and I got to learn a lot. And we end up performing every sign for aortic regurgitation, and we also appreciate the water hammer pulse. But it was very interesting and educational for me.
All right. Reasonable. You get some marks.
Okay.
All right. Yeah, I think it was okay. Maybe you can work on the flow. Since the
Yeah.
case that you're looking to present, you can work
Mm-hmm.
on the flow of your presentation a little bit better.
Yeah. All right.
Okay.
Mm-hmm.
All right. If I were to take a jab at it, okay, yes, I do have this case in mind.
Mm-hmm.
And this was of a 68-year-old gentleman who came to the hospital with complaints of worsening shortness of breath over the past couple of days. He had a past medical history of hypertension and you said diabetes, right? Or something?
Mm-hmm. Mm-hmm.
Hypertension and diabetes. His symptoms started about a few days back, associated with low grade, associated with low grade fever and a productive phlegm, yellowish in color, not associated with any overt chest pain, lightheadedness, nausea, or vomiting. On vitals, he was known to be tachypneic, mildly tachycardic, as well as mild hypoxia. Respiratory, and on the physical exam, I found crepitus in his uh, lung exam. Otherwise, chest expansion was symmetrical. I did notice, however, that he had significant um, possible prominent pulses, as well as a forceful heartbeat, as well as I heard his head I saw his head knobbing. On auscultation of the heart, I believe it was due to lack of experience, but I was not able to pick out any significant murmur, although some sounds were not fully, I was not able to comprehend the heart sounds adequately. We did find, of course, a pneumonia on the X-ray. We started him on treatment for such. Having noticed having noticed this abnormal head nodding as well as his peculiar pulse, I did address that with my attending, and I discussed that I've noticed some things atypical in this regard, and this could be a sign of aortic valve pathology. And I recommended if we can get an echocardiogram. Lo and behold, we were able to pick up a moderate to severe aortic regurgitation, which definitely was a sign that I was looking to pick up. And based on this, I went back to the patient and tried to auscultate the patient's heart again, and I was able to focus a bit more, and I found this diastolic murmur prominent in the right intercostal space and the second intercostal space along the left or along the right sternal border. And yes, so this was the first of a kind for myself and fairly interesting. The patient did come in with pneumonia, yet we picked up this and we did have a cardiology consult as well. And the patient was shifted after recuperating from his pulmonary symptoms to the cardiac ward for further evaluation. Yes, this is what I found to be interesting, and yeah, I would wanted to share this case. Hopefully, you liked hearing about this case. All right, so something.
Mm-hmm.
Anyone else? Anyone else have want to take a jab at it? Because basically, as we discussed before, they just want to know if you're able to present a case. They don't want to be entertained. You know, it's not about entertainment. They could open up YouTube and if they want to be entertained, they just want to, they basically want to see if you're able to present a case.
So can I try?
Sure.
Okay. Thank you very much. I have had many interesting cases during my short clinical experiences, but one the most interesting case that I would like to tell you here was when I was in my medical school during my clerkships in surgery ward. One day in the emergency department, they came a very young girl around 20 years of age. She came with left-sided abdominal pain and my with fever and vomiting. So my attending asked me to do a physical examination, and I did that. And he asked me about the differential diagnosis for that case. So as she was a young patient, so I gave him the differential diagnosis of like maybe because the girl was really young, so I thought maybe it might be a ruptured ovarian cyst or ovarian torsion, or it might be um, a left-sided pyelonephritis, or it might be ectopic pregnancy. So these were my differential diagnoses. So my attending asked me to go for an ultrasound scan for the patient. And to my surprise, the ultrasound scan showed that she was having a left-sided appendicitis. So she was a case of situs inversus. So yeah, it was a very atypical presentation, and it was the most. It is the most interesting case of my life till this day, and this taught me that even the um, um, atypical presentations can sometimes present to the emergency department, and you should always be on your toes for those presentations as well, and you should always keep in the mind of the atypical presentations of atypical diseases. So yeah,
All
that's
right.
it. That's a very interesting case.
Right. Very good. One thing I would organize it a bit better.
Yeah, I know.
And you basically have to, I think I missed out also, but you have to define what was your role in that patient. You were the admitting intern, perhaps, or you were in your house job and whatever. Um,
Uh-huh.
and yes, I was the admitting intern in the medical
Uh-huh.
department in the
Mm-hmm.
ER, and
Mm-hmm.
I saw this case and just go through chief um, chief complaint, past medical history, history of present illness, pertinent review system, pertinent vital signs physical exam, and yeah, in pertinent investigations and lab results, if any, and what was the interesting part? Was there a twist, as you were mentioning? So just go through a stepwise approach.
Okay. Okay.
And yeah, definitely watch the dedicated video on this question.
Mm-hmm.
Um,
Okay.
okay, just definitely watch that. All right, who's next? Who wants to give it a try? Rabia Aslam.
Um, I didn't prepare this case, but I remember one case, so I am just telling it on in my own way. This was a case in which I was working as a medical officer in a tertiary care hospital in emergency department, and there was a patient presented with the sorry of 45-year-old patient presented with the bilateral lower limb weakness, and on he was the non-case of hypertension, chronic kidney disease, and diabetes. Then on further history of his illness, we came to know that he has diarrhea for a couple of days, and also on review on review of his system, um, there was on physically on vitally he was stable, but on physical examination there was lower limb weakness, and but there was no loss of tone, and no loss of muscle there, and after that we admitted it after stabilization we admit the patient in the ward, and um, uh, we did run the labs, and we came to know that there was hypokalemia on the labs, so we suspected that this may be hypokalemic uh, hypokalemic paralysis. So we started replacement of her hypokalemia, but still the patient condition did not improve. Then we brainstorm on this, and we came to know that I discussed this case with my attendings and seniors. So we came to this conclusion that we should consider some other differentials. So keeping in mind the history of his diarrhea, I suppose the diagnosis of GBS. So they really appreciate it, and we did the lumbar puncture, and on lumbar puncture we find out that it is confirmed that he was a case of GBS. So we immediately coordinated with ICU and shifted the patient there to stabilize further for further management. So I think this was an interesting case for me.
Okay. Um, yeah, that's reasonable. Um,
Mhm.
Again, I would want you to prepare this better.
Yeah, I'll work on
You have
it.
to
Yeah.
write this down. You have to definitely write this down. And
Mm-hmm.
yeah, just practice the flow and write this down.
Okay.
If you were not there in the session for this question, make sure you watch it and
Okay.
yeah, just practice your presentation and
Mhm.
because half your interviews you will get this question. Probably
Yeah.
you will get
I
this
get it.
question, and you should
Mm-hmm.
have at least probably three questions uh,
Okay.
talk about. Um,
Mm-hmm.
it's one of those things that you need to get, you need to have a reasonable answer to because they're looking for, okay, this person says he or she did a house job, and
Yeah.
so that means they went through medicine or surgery, and every day in the morning, what happens? You have to present cases, right? So,
Yeah.
and they're saying, okay, does this person, will this person be a resident who we will have to teach how to present, or will they all, does this person already know how to present, right?
Mm-hmm.
So,
Yeah. Right.
that's just the name of the game, and they're everyone is judging everyone at all times. So
Mm-hmm. Yeah.
just be ready and be ready with, okay, what did you treat it with? Did you give IVIG? Did you do a plasmapheresis? What did you do with this patient? What was the outcome? They may even
Yeah.
ask,
Okay.
you should know about, okay, what was the treatment provided? IVIG, plasmapheresis, what was done about this patient, right? So they will all ask
Yeah.
questions.
Okay. I got it. Thank you. Thank you.
You. All right. Anyone else?
Dr. Umar, can I do that?
Sure.
Yeah. Um, I remember I saw a young patient in the ER with my mentor. She was 35 years old, a female who presented with the chest pain. She had a medical history of hypertension. She was smoker, has significant family history of the heart problems. She used to have high cholesterol level as well. She was doing fine until 2 days ago when she started having chest heaviness. And initially, she thought she is probably having panic attack because she was also having diaphoresis and shortness of breath with it, and she had history of panic attack too, so she didn't pay any attention to it. But over the next day it got worse, and it got so bad that she had to come to the ER. In the ER, when she presented, she had normal vitals. But when we got her EKG done, she had ST elevations in the interior leads. Her vitals were fine. We waited for the labs. The labs showed elevated troponin levels, elevated troponin enzyme, but rest of the labs were pretty unremarkable. um, since she was having ST elevation, so we call STEMI alert, and she was taken to the cath lab. In the cath lab during NGO, she was found to have spontaneous coronary artery dissection. Being a medical student, I haven't shown this one before, and it was something which was very interesting for me. Um, Although there was blockage from the spontaneous coronary artery dissection, but my attending chose not to fix it because attending told me that it was from some intramural hematoma in the young female, and usually it heals upon itself with the conservative management. Going back home, I started reading about the spontaneous coronary artery dissection, and I found out that every 9 female out of 10, every 9 out of 10 people are female, because they have high estrogen level, and estrogen make the arteries fragile and soft, so they can have dissection at any time. This is what the most interesting case that came to my mind when you asked me to present a presentation.
All right, so I think you did a good job. You went through the steps and it was pretty clear. One thing I would say is that was the patient still having chest pain when they did the EKG?
Yes.
Okay, so as soon as you see a patient with chest pain and an EKG that is indicative of ST elevation, then you necessarily don't want to wait for the troponins to call a STEMI alert.
Okay.
Uh, so that's just a little bit of a caveat that they may ask, okay, so you hopefully you didn't wait for the troponins to come back after an hour. To,
Hmm.
I mean, that's just saying. And you can say that, okay, SC segment elevation was noted in the anterior leads, and we call a STEMI alert. Subsequently, labs also returned, and the patient was taken to the cath lab, demonstrated coronary artery dissection. So yeah, that's how you could just
Perfect.
refine this a little bit.
Okay. Thank you.
Anyone else? Last person.
Yes, can I go?
Sure.
Okay, thank you. Let me build the ground first. I started my house job, and before that, I was doing my rotation in the United States in Oklahoma Heart Hospital. So I had seen a lot of cases with raised JVP. When I went back to Pakistan and started my house job, it was almost first or second day of my house job, and we were having a round inside the female bay along with the professor and all the staff. There was a 40-year-old female who was having shortness of breath, and the resident was discussing the case with the professor because the cause of the shortness of breath was not uh, like it was unknown, and she had normal echo. And the professor and the whole team had approximately 30 hours of discussion, 30 minutes discussion on like to rule out the cause. So what's the to know the cause behind it? So I was just looking at the patient, and uh, I observed that her JVP was raised, and I just deliberately bent down 3 or 4 times to just look at the JVP, and the professor then asked me that, "No, what are you looking at?" Probably he has got that I was looking at the JVP and it was raised. It was going up to approximately in front of the earlobe, till the earlobe, and so the cause was. I said that she is in fluid overload. The whole floor appreciated at that moment, and I thought that if we like have the expertise, then we can bring changes to the like human lives, and we can save them.
Okay.
Yeah, thank you. I think that's what.
All right. So you could probably add additional aspects.
Yeah.
Lungs were diminished, perhaps. Patient had lower extremity edema
Mhm.
and
Okay.
it appears short of breath. Um, that was not immediately focused on. However, this was a very quick um, interpretation of the patient's presentation that you can easily
Mhm.
just pick up on these patients and get to a conclusion in a matter of seconds, perhaps.
Yeah.
Okay.
Okay. Thank you.
Okay, so if anybody wants to give it a go, the last person, we can do it. Otherwise, we will call it a night, a day, wherever you are.
I want to discuss another case, but if everybody is done, then
Anyone? All right, so you can go ahead.
okay. So I think this was an interesting case that I came across in respect to neurology. Um, a 1 month old infant referred to us due to initially presented in an private clinic with the complaints of lethargy, fever, and dyspnea. They work it up. They work him up for neonatal sepsis and meningitis. So they initiated broad spectrum antibiotics, but her head circumference was enlarging, and then they referred the patient to us. So when the patient initially presented to us, he was he presented with enlarging head circumference. Vitally, he was a little tachypnic, tachycardic, and have a low grade fever. Sats were O2 sats were 92% at room air. On physical examination, we could appreciate an enlarged head circumference. And otherwise, there were some small. We can also appreciate crepes in the lungs, and all the other systems were unremarkable. So on investigation, the CT had showed actually hydrocephalus, and we suspected it to be a complication of meningitis. We also perform lumbar puncture on him, and it shows increased leukocyte count we were awaited culture. The culture came out to be producing a very rare bacteria called Actinomyces Acinetobacter baumannii. Sorry, it's Acinetobacter baumannii and it shows pan-resistant, and it was only intermediately resistant to solestin. So this was a case of pan resistance and a very rare bacteria that don't usually affect infants of like this young. We had very limited options for the treatment, and it is and we work in a very resource limited country. After a careful consideration and research of the literature, we ended up treating that patient with intrathecal solestin and frequent ventricular taps. After that, the patient started improving in like about a 2 month period. We follow up that patient after that, and the culture came negative, and it was a very interesting case to me and to everybody else too, and it also showed the importance of antibiotic stewardship. So I ended up writing a case report as a first author on that particular case, and it's in the process of submission. So I think this is really interesting to me and to everybody. It should be to you too.
Yeah, so good. I mean, the case is good. I think you probably realize just have to work
Yeah, I
this case.
had it in.
Yeah, that's fine. Make sure you write these things down.
Yeah.
Make sure it's written down.
Mhm.
You go through it, just read it a couple of times, then regurgitate it from your memory.
Yeah.
One thing, maybe I missed it. With the pediatric cases, you have to generally mention the age. I think you did mention something, but maybe not the age because that describes a lot about
No,
a
I did. It's 1 month old infant.
Yeah, I missed it. Yeah. Okay. Yeah, just work on the flow.
Yeah.
Work on the flow, and think there were one or two points that came up. Um, one or two points that came. Anybody, any thoughts about this case? Or any feedback for her? Yeah, I'm thinking.
I have another question other than this case.
Okay, let me just think a little bit about it. I was remembering something that I wanted to say. Um, yeah, I think. Okay, maybe it'll come to me later, and then I'll let you know. All right, so Hassan, yes, last person.
Basically, I want to ask, like, sometime we apply in the peds as well, like with one rotation. So how we can convince them that we are peds enthusiasts as well?
Right. So what do you think? How will you convince them?
Like even though a few residents get matched as well with just one rotation.
Yeah, I've seen people with just one interview and they match. So one would you can. So how will you answer this question? So Dr. Hassan, so I see you have lots of experience and background with internal medicine. However, it seems you are here for a pediatric interview. So, um, are you sure you want to do pediatrics?
Uh, I guess when I did
Yes. You don't get don't say you guess. Okay, I'll let you answer. Okay.
so basically when we have like five rotations from the IM and like just one with the peers, I'm not like I'm myself not that much convinced that I will be able to convince them that I am peers enthusiast.
No, no, but you convince them. I asked you the question, right? So, Dr. Hassan, so I see all this experience in internal medicine, but you're here for this PEDS interview. This looks
So
funny to you, right? Or no?
so when I did my clinical internship during my house job, and I did my peers rotation, and then I started developing interest in peers. And when I came to United States, I was not able to get all my rotation in pediatrics, but I got one in peds. And then after doing that peds rotation, I did some research work on the peds population as well, and then volunteer work also shows uh, my like I do have interest in pediatrics as well. So another thing that I would like to mention is the inpatient uh, kind of like I believe that whatever the experience that I have got from internal medicine, I can use it in the pediatrics as well. So I think there are so many things that are parallel. It's just about the age, and I don't believe like it would be a bigger difference for me.
All right, that's reasonable. I think you just have to work on presenting it properly. Yes, definitely, that's a good question. And I believe that I think I will be a very capable peds doctor, physician, and a resident. And I do believe that whatever education, whatever experience that I have in internal medicine definitely also carries over with peds, especially in a higher children's age group. But I do want to mention that I had a peds experience back in Pakistan. And when I came to the US for US clinical experience, it was a bit more difficult time to obtain a peds a peds observership. However, I was able to obtain this observership and that was a very good experience for myself. Subsequently, I also worked in a project, in a peace related project. And yes, I've always felt I could be a doctor for adults. I could be an equally good doctor for children. I know there's a bit of a difference, but not much.